Hi, my name is Jennifer Young, and this is my research presentation, Produce Prescriptions, a Policy Solution for Public Health and Cost Savings. As an introduction, I would like to introduce you to four different things. First is the research question. What is the impact of produce prescription programs, also known as PPRs, on health outcomes as well as healthcare cost? And what models exist that best achieve sustained success? Also, the problem. So, the problem is chronic diseases such as type 2 diabetes and obesity are driven by food insecurity, which includes a lack of access to healthy food, which costs the US 1.1 trillion annually. So, on to the policy intervention, which is produce prescription programs. As I said, also known as PPRs or as the Food is Medicine movement. The goal is to shift public resources from being reactive in healthcare to being proactive in community based prevention. Theory and foundation. The theory is social determinants of health. So, health is determined by your environment, such as food access, not just individual choices that people make. PPRs directly alter this environment in such a way that they actually promote health. According to the literature, PPRs significantly increase fruit and vegetable consumption. Studies do show measurable reductions in hemoglobin A1C and blood pressure. There are economic models that project the cost savings in the billions by preventing acute care. So there are three hypotheses. One is improved clinical outcomes such as BMI, which is body mass index, and hemoglobin A1C, which is blood sugar. The second one is reduced healthcare utilization, such as emergency department visits and cost. In addition to that, local delivery models are found to be most effective. Methods. So the design was quasi experimental, both pre and post test. The sample was purposive, non random, which involved 100 participants that were chosen for their high risk profile, such as low income and being food insecure. The data sources were mixed, as in quantitative. That was clinical records for BMI, which is body mass index, hemoglobin A1C, and emergency department visit counts. There was also qualitative, which was participant surveys measuring self reported consumption and food security. There was a trade off, though, because the non random sample, while it maximized internal validity, proving that the program actually worked for this particular population, there were limits on the external validity because of the generalizability. Regarding the findings, there was success with health and diet. The average daily fruit and or vegetable intake increased by 2.5 servings in the treatment group. The clinically meaningful average reduction in BMI or body mass index was zero point 0.8 points. and the average drop in hemoglobin A1C was 0.5 percentage points for diabetic patients. There was also an economic impact where the average emergency department visits for chronic conditions dropped from 0.6 to 0.3 visits per person in 6 months. There was also success with implementation. Self-reported food insecurity dropped from 75% all the way down to 20%. There was a challenge with the data collection. So there was no way to get precise dollar cost savings from multiple insurers. So you had to focus on the tangible metric, which was visit reduction. With the discussion and implications, there are some things to consider. First of all, the theoretical conclusion. The findings validate that the social determinants of health theory altering food access is the most effective way to improve health outcomes in this population. There are a couple of implications for public administration practice. One surrounds policy, where there needs to be some prioritization upstream for preventative spending over reactive acute care. The second area would be funding, where policymakers must secure sustainable funding via Medicaid waivers or direct health department budgets. While the method was non-random selection, it did introduce some potential bias, but the consistency of the clinical and economic data strengthens my confidence in the results. Recommendations and conclusion. So, regarding future research, there's three areas that must be addressed. One is to conduct a large scale randomized controlled trial to eliminate any selection bias. Second would be to execute longitudinal studies, which that means 2 or more years, to determine the long term cost savings and durability of the health changes. The third thing would be research the optimal dose and duration of the produce, meaning how much and for how long. In conclusion, PPRs, produce prescription programs, are an effective evidence based strategy to improve public health and reduce healthcare costs. They offer a clear return on investment for any community looking for a fiscally responsible approach to chronic disease.